Anybody work with somebody that had a catheter in place?
Yes.
Yes.
Yeah.
And a colostomy bag.
And I'll talk about that too. Here's a Foley catheter. This person has very yellow urine. How do you think it would attach? Yep. There's usually a balloon on one end. It goes directly in the urethra. Once it's in, it goes up into the bladder. The bladder is filled with fluid, and that's how it stays. Or excuse me, the balloon is filled with fluid, and then that's how it stays in place. Yes, I pulled that out. Brenda is a very big proponent on when you have a catheter, you cover it up. Some people are very self-conscious about it, and some people really look at it and I will not walk in the hallway, I don't want it. Men are very, pardon me guys, men are very sensitive to having things hang. Women tend to deal with it a little bit better. Very easy to get tubes kind of caught up in the walker if you're walking with a walker. So things to think about here. Is it wrong for you guys to work with patients that have catheters in place? Mm-mm. Not at all. There are other forms of catheters. You could have like a condom catheter. Anybody here work with one patient over at Scholastica? He has a condom catheter. Sits on the penis just like a condom, and it collects in a bag. That one, very easy to pull off. Whenever you are working with a patient, you should never be holding the catheter bag up. It should always be below the bladder. It's gravity. Gravity helps pull the urine out, right? So think about that when you're working with a patient. If you're walking along and you have the catheter hanging on the front of their walker, is it above or is it below their bladder? Questions? Oh, I should tell you, this does not have, typically, once the balloon is in place, they're going to attach this somehow maybe to a leg. There are some straps that they can use that attach to the thigh to hold it in place. They work, some of them don't work. Kind of a trial and error. Some patients like it, other patients don't. So I've also seen it where they've just taped it in place. IV tubing, lots of different tubing, right? Very easy to look at somebody and say, okay, this one, I just realized there's a person on the floor. Anybody else see that? Yeah, that's nice. Yeah, it kind of is.
What?
Not quite sure.
Oh, is the mannequin on the floor? Is that she's saying?
Yeah, it was already, already saw it like that. Just,
It's a real person?
I thought it was a real person at first too. Okay, so here's an IV tubing. You guys can see this? Everybody can see it? Okay. What arm is it? The right arm or the left arm? Good point. You might have to get up and move. So, here's an IV. It's attached into the forearm with a needle. Most of the needles are very flimsy. They'll insert a needle and then they'll pull the needle out and then leave a little filament in. That's how it's into the vein. Various different places that they can put these in. Hands, on the front of your hand, on the dorsum of the arm, of the hand. Anything here could be radial, it would be like an arterial line. Forearms, a lot of the times you're going to see them placed right in the antecubital space. If you think about working with a patient that has any of these in place, how is that going to affect using a walker or an assistive device? If I have it right here on the back. Yeah, it might even occlude it. So you have to think about what you're doing. You might have to cue patients a little bit more to change the hand positioning. Antecubital, I've seen them up in the arm, the upper part of the arm. Some of them actually have interjugular. I'm losing my word. Yeah. I've seen some femoral, some arterial lines that'll be femoral where I can't bend the leg up. I've also seen them in the foot. The foot is usually one of those last axis places that if they can't get somewhere else, they're going to end up going into the foot. Can't do much. They can bend the ankle, but if that's like their last spot that they have, you got to be very careful. Over there on that bed, so you have just a regular IV site, right? And then you can have arterial. What would an arterial line mean? What was that? Right, it's going into the artery. They can get blood gases from there. If I were to pull that out, think of the pressure of what is going to happen there. Blood is just going to squirt. Where if I pull an IV out, a regular peripheral IV, it'll bleed, of course, but it's not going to have the pressure of my arterial line. If I were to pull an arterial line out, you need to put direct pressure on it and hold and hold and hold and hold. And of course, if you pull anything out, you need to get a nurse or get somebody there to help you. One thing that I have always gotten in the habit of is wearing gloves. I am not afraid to put on gloves as soon as I walk into a patient's room. Even in treating some patients now, I will wear gloves. So don't be afraid to look at it and be like, oh, a patient feels like I might be treating them any differently. Hey, if you're working in a hospital or a skilled nursing facility, you might be dealing with urine or feces and you might not even know where it is. Right? It's really easy for patients that have memory issues to forget, oh, I was just scratching my bum and I had stool all over it. I didn't know I had stool with my bed. Okay. So this is a central line going directly into the heart. Has anybody heard of a PICC line? Yeah, peripherally inserted central. So you'll often see a PICC starting in here, and it'll have direct access to the heart as well. So this is also a central line. I'm assuming this is going not quite positive, just anatomy-wise here though. Anytime I see those are for mostly long-term antibiotics. Usually there's a little bit more health issues going on if I need a PICC line or some sort of central line. Patients going through chemo often have some sort of line placed as well. It's not necessarily the same as the central line though. IV machine. Let's see. This is gonna have to work. So, whether this is an arm, I'm not positive. But here's my IV machine. If this thing is beeping, obviously there's something wrong. I'm not skilled. It's out of my scope of practice to push any buttons on here. I would have to get a nurse. If it's coming up and saying line occluded, it'll say occluded over here. I can't do anything about that. I need to get somebody who's skilled in this to deal with it. I might hit silence because it's been going off for 15 minutes and I'm waiting, but I'm not going to touch anything on here. I might have 10 or 15 bags hanging. That's very possible, depending on where you are in whatever facility. I have seen a lot. You guys seen like when people go fishing in Florida and they always come out with those big hooks, like big lines, and then they've got like 4 or 5 different fish hanging from them? I've seen that with IV bags. They had 22 different IVs hanging on one patient.
What would be the reason for that?
Lots going on. It was brain injury and spinal cord injury, like you name it. Hemodynamically, they weren't stable, so they were trying to fix what was going on. So this is very minimal. Am I doing anything with that patient that has that many bags of medications running? Chances are probably not, but I still have to be aware. Anytime I see an IV, I always want to know, where's it going? Where is it attached? What arm is it attached to? Is it attached? Because it is very easy to pull them out. Any questions? Okay. All right, so let's go over here. So, what is this? Right, it's a face mask. I've got oxygen going directly in. Sometimes patients have a hard time receiving oxygen just in the nose. Some people are mouth breathers. So you'll end up seeing people taking an O2 tubing and actually putting it in their mouth. That's how they breathe. They don't breathe through their nose. This is a face mask. Is this going to fill up? No, not necessarily. But this is going to be where they're going to get pure oxygen through the nose and through the mouth. It's attached to the wall. Can you guys all see? You can see that one over there. There's always one end that has to be attached to something. This might be something else that I might attach to a portable oxygen tank so we can go for a walk. Whenever I attach this either to the wall or an oxygen tank, I never stand directly in front of them. It is direct pressure. Think of all the pressure that's built up in an oxygen tank. It's pretty heavy. There have been research that has been done that I have not personally read, but I have been told about it by several people. Think of the pressure that's coming out of here. There has been nurses who have went to put things in and it's shot out of the wall and hit them directly in the face. Permanent permanent damage in the eye as well as some facial fractures. There's a lot of pressure. So I never personally stand in front of it. I don't need to, but I'm always going to hold on to one end because this is pretty wobbly. And I put it back on. To adjust the amount of oxygen that you need, you turn the dial up or down. You look at the little ball that's in here, little silver ball. It's going to rise up and down depending on how much oxygen is being delivered. I always go by the middle of the ball. Whatever line number that the middle is at, that's the amount of oxygen that they're getting. Is it in your scope of practice to change the amount of oxygen a person gets?
No.
There's a range.
Right. So if we got up, I took off their oxygen, I turned it off for some reason, we went on to a portable, came back, I'm going to put it at that same one that we started at. I might go talk to a nurse though and say, hey, they did great on the 3 liters of oxygen, they maintained above 95 the entire time, and she might say, let's turn it down. That's great, I can do that, right? I'm never increasing it more. Some people talk about what is the right way and what is the wrong way to actually put a nasal cannula on. I can't tell you right or wrong because some people like it, they put it in and put it over their head. Other people will put it in and put it on their ear. I have seen so many different ways. I like to ask people though. One thing you have to think about with the nasal cannula is when it goes around the ear, if I were to put this in, that goes in my nose, right? If I put this around my ear, this could potentially be a pressure point. If I am in bed all day long, I'm turning from side to side, somebody's helping me. If that's going over my ear, that could cause a pressure sore. So sometimes they put little padding on it just to help give it a little support. Not all the time, but sometimes you'll see it. I'm looking.
Oh, yeah.
I have seen, this little FYI too, some very short IVs. Like I've seen short, and I have seen super, super long ones. The same thing goes for oxygen tubing. If I have one that can barely touch the wall and the patient can't turn side to side in bed, we're probably going to need to get a different one. Is that my job? I could do it. But if I don't know where something is, I might have to ask for a little bit of help too. I have gotten in the habit when I transfer with patients to always transfer away from where their tubing is coming from. Can I tell you that's the best option? Not necessarily. I'm very, very aware of where everything is because of everything that I have pulled out. It's all been on accident, by the way, too. But if I have a tubing that's on my left side and I'm trying to transfer to the left, what are the odds that I'm going to end up sitting on it? Or the patient getting tangled in it? Pretty good. So at least if I transfer away from where it is, then it potentially could be in front of me or on the side that's closest to where they're coming from. Any questions? All right. I'm gonna go over here. So, what does this person have? Yeah. So it's a cut. They make a hole in the trachea and put a tube down it so the person can breathe. Typically, you're going to see patients who have been intubated for about 2 weeks that will end up, if they still need to have intubation, they will end up getting a trach, give or take, but about 2 weeks after they're intubated. It's usually meaning that they're going to have more prolonged intubation that's required. Most of the reason why they do that is to help decrease the swelling that can happen in the throat as well. So this is, these are, I don't want to say easy to pull out, but they're there. I actually have tubing, which we'll see in the other one. Oh, this guy has it. Sometimes they'll use these as a tent that will go over the front of the trach. Other times, if he's actually mechanically ventilated, there's a component that I'll show you in the other room, how it's connected. This can pop off fairly easily, right? This is not very long at all. So you have to really be careful when you're trying to help roll with a patient, or even if they're getting up, because patients can walk on these. They can walk with this. They can walk with a trach. They can function with trachs, right? If I were to pull this trach out, do I reinsert it? No. No. I would immediately call for help. There are some instances where it might kind of dislodge a little bit. Am I going to push it back in? I'm probably going to call for help right away.
I did some observation hours with infants, and they have trachs and everything, and like just the covered half of the top part of the trach would come off, and the PTs would just.
Yeah. And part of that is too knowing what your facility is going to allow you to do. Is it out of the scope of my practice to cover this up to help a person talk? No, I can do that. Am I going to pull it out? No, I don't want to do that. But I would not put on a passing mirror valve. Does anybody know what a passing mirror valve is? So I'm not a speech pathologist, but what it is there's a cuff that sits around, I can't pull it up, that sits around this trach that prevents air from going from here up, out the mouth and out the nose, right? They have to deflate that cuff because it's not allowing air to pass through the vocal cords. So once they do that, they can put this passing mirror valve on so a person can talk. I do not put that on. I would either have the nurse or I would have the speech pathologist there to help do that. Some patients are very able to do that on their own as well, depending on how long they've been dealing with this type of injury. I will warn you, never stand in front of a patient that has an open trach like this. Patients cough. It's very irritating to the throat, and it is a very forceful amount of air that comes out of it, as well as mucus and anything that is in there. I was working with a patient, and they had a bed at the foot, or they had a TV at the foot of the bed, and he had a trach in place, and it was covered with stuff. So, things to think about. Am I going to stand in front of them? If I have to, absolutely. But I want to be aware of where everything is, too. Because they might not be coughing. They might not have any problems. So what is this? What? Yeah. Yep, it's a feeding tube. There are different ways to describe a feeding tube. It can be an NG, so it's nasogastric, so it's going into the stomach. It could be an NJ, could be going from from nasally down into the jejunum. It depends. Do I necessarily know which one it is? Nope. But I can tell it goes in the nose, right? I would have to ask the nurse for sure which one is it. Does it matter when I'm treating them? Is it NG or J? No. There are little numbers on here. Very hard to see, but there's numbers on here, and that tells how far it goes in. So when they say, once it gets in place, there's usually a little wire that's in there. They'll insert it down through the back of the throat into wherever it's going. They'll leave the wire in place. They'll take an x-ray. So when they take an x-ray, they can see in the body, in the chest cavity, in the stomach, where it goes. That's how they know, is it in the right spot? Then they can adjust, oh, I need to move back 2 centimeters, I need to move ahead 4 centimeters, whatever. And they look at these numbers. Once they have it in place, they're going to tape it onto the nose, and they're going to pull that wire out. You'll usually see the wire, at least at our facility, it'll be taped onto the wall. It'll be in a bag, taped onto the wall in case they have to reinsert it and reposition it. I do not do anything with this. These are very short. This is hooked up to suction, so it's a little bit different than being hooked up to tube feeding. I don't see anything in here. The reason it's hooked up, if it were hooked up to tube feeding, the person would be getting nutrition. Typically, that person's getting nutrition either can't digest anything or they can't swallow. So if they can't swallow, how are they going to eat food? Maybe a patient that had a stroke, maybe having some swallowing difficulties, they might have an NG in place. NJ. Now, if I have it hooked up to suction, what do you think that's for? Sure. It's going to be sucking something out. So typically, if it's to suction, we might say they might have like a bowel obstruction. So things are backing up. It might be, it's going to connect over here into this canister, and then it's hooked to suction here on the wall. If it's sucking something out, it's going to be stool. The body can't pass it rectally, can't go through in the intestine because there's some sort of blockage, so they need to take it out the other way. This is often used if they need to administer some sort of medication. Since they can't swallow it or eat it, it needs to go directly in. They'll crush it and they'll put it in here. Meds can be taken through the NJ. Usually they're crushed, obviously, because they need to be able to fit through this tiny little hole. You guys have any questions so far? If I were to accidentally get a patient up, all of a sudden I realize my tape is now hanging down here and it's barely hanging in my nose, what am I going to do? Am I going to push it back in? No. I'm going to call for help. The nurse might come in and push it in. She can do that. I'm not doing that. It's not my job. If I all of a sudden realize, oh, the tube feeding's running, it's all over the floor, I'm going to pick it up, probably going to hang on to it and then give it to the nurse when she comes in. These are really easy to pull out. Working with patients, I'm never going to come in and I'm never going to whip off a sheet right away. You think that patient's going to like you? No. You might do it once and then you're never going to do it again. But I always try to be really cautious and tell them exactly what I'm doing. But in the process, I'm probably pulling down something while I'm doing that. Okay? And if I just have to get to the belly, I'm probably going to leave things open and still drape. Y'all learned about draping already, right? So this person has a what? Yeah. So what am I going to be worried about when I have a colostomy bag? Sure. What else? put right across here? I do put a gate belt. This is open. I can't. So that's the intestine. There's usually a little hole, the intestine's right there. That's where my stool's gonna come out. There's been some sort of surgery, whether it's a resection or whether it's a some sort of obstruction that ended up resulting in a colostomy bag. The colostomies have some really awesome tape. You're fine. You're fine. It sticks really well to the skin. Usually wound care will come in and teach that patient how to change the bag. That's out of my scope of practice. There have been times where I've come in and I've seen the bag be filled up to here, full of gas and full of stool. I am not touching that. I've had several patients go, oh, I'll just empty it, get me this. Sure, I'll do that, but this is out of my scope of practice. I don't need to do that. I have had it where colostomy bag has fallen off and literally had stool all over the floor. So whether the patient had moved a little bit, sometimes the tape does not adhere as well as you want it to. So I like to just check it to make sure, is it in place? And I'm not going to be hitting them, of course. But this is gentle. This is that person's intestine. If I were to grab your intestine, I'm pretty sure you'd be pretty uncomfortable. Here's your bag. Fills up from the back, stool will come in. It's going to fill with gas too. So if you're really, really gassy, this bag's just going to fill with air. So oftentimes what they have to do is what they call burping. They're going to open the bottom up. It doesn't fall. And they're going to let the air out. Makes sense, right? Do I do that? No. And different bags have different ways of opening and closing as well. So, like I said, this is out of my scope, but it's good to know. Where is it? Is it always on the left side of the body? No. It might be a little higher, might be a little lower, it might be on the other side. I'd have to look. That's where when I do my chart review of my patient is going to come into play. I have gone in several times into rooms and thought, oh, this is great, you only have an IV. And then found out later, oh, you have a colostomy bag. I wasn't aware of that. And I do pretty thorough chart reviews. So to miss something like that is kind of a big deal. So really being able to look and say, okay, did my supervising PT write in there they had a colostomy bag? Not necessarily. Not necessarily. I can walk patients with these. Patients swim, patients cycle, patients run. Patients live with these. Because once they leave the hospital, some of them have them for months, some of them have them for the rest of their lives. Some people have it where they're going to be able to do a colostomy takedown, where they're going to be able to reattach the intestine later at some point. Really depends upon what the situation is and why they needed to have it. But you can live a typical life. Patients might avoid putting pants or something that goes right across it. That's okay. Some people you might even know not even have one. Or you might not even know somebody has one. There was a huge ad about this young girl that had a colostomy bag and she was a supermodel, or a swimsuit model. Did you guys all hear about this? Yeah. She's a swimsuit model showing off her colostomy bag. I think it was actually Sports Illustrated, if I'm not mistaken. It was something big. People live normal lives. So if I do have this here, where would I put my gate belt? Yeah, I might go a little bit higher. Depending on the location of it, I might be able to go a little bit lower. I'd want to pay attention to it. But if all else fails, I'd probably go right underneath the armpits. If they're female, I'd readjust, of course. But questions? No. This is a chest tube. The reason I say no, kind of, chest tube is going to go directly into their chest. And it's usually there either if a patient has a hemothorax, which is blood in the lungs, to drain out whatever happens to be in there. We will often see patients who have had some cardiac surgery, cabbages, whatnot. They might have 2 or 3 of these in place due to a lot of drainage and a lot of bleeding. I never want this above the patient. It always hangs lower. It is hooked up to suction on the wall as well. I will never remove somebody from suction when they have a chest tube unless I have clearance from the doctor. When it is on suction, it is actually physically sucking the stuff out of the chest. There are some physicians that are very, very particular about that, where it will say chest tube to suction, or patient may ambulate on water seal. Removing this would be water seal, and then reattach the suction after. So before you do anything, you want to make sure you know what am I getting into. This is what it looks like. As it drains out of the chest, it fills up each individual column. It starts here, fills up over. If I were to kick this over, which is very easy to do because it's usually sitting on the ground, it's going to start filling up a different vault. They're measuring every time a nurse comes in to look, they're measuring to see how much output has there been. So if I dump it over and it fills up these other 2, all of a sudden this one's completely filled. What's going on? So they're going to come in depending on how much they're measuring or how often they're measuring, and they're going to write, noon, 4 o'clock, 6 o'clock, and the date. So they know, between these hours, they put out this much. Oh, you know what? For the past 3 days, only 200 milliliters were put out. We could remove that. This is not something that I would ever remove. They're usually, you're not gonna be able to see this. They're usually sutured into place, and as well as putting in like an ABD pad or some sort of dressing over it. Can you walk a person on it? Absolutely. If it's cleared by the doctor. Is it easy to move? It can be kind of a pain in the butt because where am I going to hang it? If I have oxygen, an oxygen tank, I have an IV pole, I have a chest tube, and I have a patient, how am I going to do that? It can be a little bit difficult. So I'm probably going to have somebody else. This does have little hooks on here that actually fold down. So if you ever do need to hang it up, they're right there for you. I could hook it onto a walker. Okay. If I go to put somebody back into bed, I also want to be careful of where are those tubes. Is my patient laying on it? Is it ginked? Same thing with IV and oxygen tubing. Anything, any kind of tubing. What's going on? Because it's very easy to kink something and not realize that you did it. So being very cautious and being very aware of where everything is and when you're done with it, and putting things back to how you got it. And the nurses will be very appreciative of that. What would this be? Ventilation. So this is an ET tube. What does ET stand for? No, not that. Endotracheal. That's going in the mouth, going down through the trachea. Do you see how short this is? Can I work with a patient that has this that's intubated? Absolutely. I have to be very careful what I do because they're connected to the lovely ventilator machine over here. I do not touch anything on the ventilator machine. I don't even silence anything on a ventilator machine. I can look at it, and that's all I will do. That is not, it's not in my scope of practice However, if I had a lot more education and felt a lot more comfortable, there are physios over in Europe and Australia that actually do work directly with patients on ventilators like this. Could I do it? Absolutely. Do I want to? No. I have taken the opportunity and done enough education where I feel comfortable to walk with patients on a ventilator, but it has to be the right patient as well. That being said, this is a suction. They actually open it up and they're gonna put it down. This is not something I do. This is what the nurse does. They'll stick this down, they'll clear out the throat, pull it back out. Oh my God. And clear out the throat. This is gonna be attached with something, whether it's tape. They've gotten away from tape due to skin irritations that people end up having. So they have like some Velcro things that they'll attach here and then around the head. Works pretty good. Again, you see the numbers on here? That is how they know how far the ET tube was put in. So this one is at 26 centimeters. That's how far down it goes. So if we roll the patient onto their side and all of a sudden I look and go, oh my gosh, they're at 10. Obviously something got moved, right? I have never pulled this out. I pulled just about everything else out, but I've never pulled this out. This is something I have feared about doing because these lines are very short. So being very aware of where they are and how they're attached is really, really important. Nursing staff, and depending on what type of facility you're in, vent houses, people go there and they're on ventilators. People do a lot of therapy with them there. Some people walk on ventilators there. Some people don't. So I know at our staff or at our hospital, they're really good about working with patients that are on vents. We just have to be really aware. If they're in the ICU, because that's where they're going to be with this in place, there's going to be a lot more stuff going on. Like I said, you're probably going to see IVs hanging off the patient. The odds of them having a catheter are pretty good. There are things called fecal pouches, which I don't believe is on here, but I think it's pretty self-explanatory what a fecal pouch is. Same thing as a catheter. They insert it rectally. They'll put fluid into this little bulb that will sit right up into this, right above the sphincter, and the stool will drain out. If it's form stool, obviously that's not going to work. This is when you're talking about liquid stool. That may be attached to the bed as well. If a patient has a femoral line, they're going to be in the ICU. The odds of them being out on the floor are pretty slim. The odds of them having any intravenous line through the femoral vein or through the femoral artery are pretty slim. They're going to be in an ICU setting. So they're going to probably tell you, I can't move that leg past 45 degrees. That being said, arterial lines, you're going to see them in the ICU setting as well. Ventilators can be set either to BiPAPs or CPAPs, depending on if they're trying to wean them off of a ventilator. I don't do anything with that either. You're not going to touch it. But to be aware that you can look on some of the ventilators and see what setting they are at. If you are curious and you're not sure, and you're thinking something's beeping at you, that's when you need to talk to the nurse and ask them for help, or have them give you a little bit more direction as to what's going on. Typically, they're going to tell you, are they weaning? Are they trying to get them off that ventilator? Or are they 100% ventilated? If they're 100% ventilated, that ventilator is doing all of the work. They're not doing anything. They probably don't need therapy at that point. If they're at 75%, sure. They're breathing about 25% on their own. But does that make sense? Or dialysis access. So typical dialysis access is going to be in the forearm. They're put in surgically. So when a patient goes to dialysis, typically they're gonna be going about 3 days a week due to what? Yeah. Kidney failure, something wrong with the kidneys, right? So they're gonna be there, they're gonna access it. I'm not gonna use that arm and check their blood pressure. They're not usually putting anything in that arm, no IV access, nothing. So they might have a wristband that says, don't use or something like that. If you're in a hospital setting as well, you're gonna probably see if they're a fall risk. They're gonna have a wristband on. If they have allergies, they're gonna have their wristbands on. Like I said, if I'm in the ICU setting, they're gonna have a lot more attached. They're gonna have EKG lines. They might have, like I said, the IV, just depending on what they're trying to look at. So trying to get them from here to that chair over there is gonna be really hard. So you really have to be aware of where is everything going. And am I gonna do that alone? No. If I'm in an ICU, I'm always asking that nurse, if not maybe somebody else, to give me a little bit of hand, because the last thing they wanna do is replace something that I've pulled out. Can you guys think of any questions?
If things do get pulled out, do you like wait until someone comes?